Let us start our invited speakers forum. And Dr. Hammad Ather is a very dear friend of mine. He is a professor who doesn't need any introduction. We all know him. He has made his mark on the scene of oncology, uro-oncology, particularly in our country. And he's an examiner and a professor of quite a long standing. So I invite, without saying much and without wasting our time, Dr. Hammad, the podium is yours.
Thank you very much, Asad, for very kind words. So without any further delay, I'm going to start right away with the topic. That's an interesting area, which is small renal masses. And when I and Asad were medical students, we the renal cancer used to present with what is called the Gravit's triangle, or triad, not triangle, actually triad, which is pain, hematuria, and a flank mass. However, a vast majority of tumors nowadays do not present with either one of these things, and it's very rare to find somebody who presents like this. Vast majority presents in a much earlier stage now. And we are going to see, if you detect tumor before it is symptomatic, how do you deal with it? Asad, I'm not sure if the audience have because they're not individually logged in, they would not be able to write in the chat box, right?
Right. So we can take the question and answer session at the very end.
Okay.
Or if you want to, we can have the interactive session right in the middle of it.
Yeah, I had some built-in questions. And
right.
So maybe anyone who is sitting there would take the answers and just type A, B, and C and D in the various MCQ questions that I have during this talk. If it's possible, otherwise a show of hand would do.
Right. So I'll be the moderator here, and you just show the slide and I'll ask the audience.
Great, thanks. So I start off with a case, and this is all, whatever we present is actual real life cases. So this is a 76-year-old lady, known case of diabetes and hypertension. She is a recurrent urinary tract infections. She had an ultrasound for microhematuria, and this is an ultrasound. And as you can see, where I've put an asterisk, is a solid renal lesion in the right kidney, on the upper pole of the right kidney. It's purely parenchymal. It is partly intra parenchymal, mostly endophytic. So obviously after this, she ended up having a CT scan, and that's the time she presented to us. And this is one of the representative section from her CT. And as you can see, in a contrast enhanced CT, you've got a solidish lesion, small lesion in the upper pole of the kidney. So my question is that in a patient who is 76 years of age, diabetic and hypertensive, how would you make the decision whether to do active surveillance or do treatment? Would you base your decision on age and comorbid conditions, like she is 76 and has comorbidities? Would you base it on the tumor size alone, or would you base it on adverse pathological features? And those of you who are not introduced to adverse pathological features, I'm going to talk about them a little later in the presentation. Or you would use all of the above to make the decision.
So how many of you are with A? Raise your hand, or B or C. With A, how many of you are with A? 2 of you. How many with B? No one. How many with C? So there is a silent majority. Are you with D, or you are with D? So the majority is with D.
Perfect. So I don't think that I need to continue with the presentation. You know everything. Thank you very much. Let's go home.
Or that's the
Right.
beauty of.
Yeah, that's the beauty of it. So is there a size limit for use of thermal ablation therapy? We know that the small renal masses can also be managed by thermal ablation, other than partial nephrectomy or active surveillance. So yes, there is a size limit for thermal ablation, like cryo or microwave or radio frequency ablation. No, there is no size limit. And this, or C, that the size limit for cryo and RFA is different.
So what do you think, the crowd, the audience?
See, sir.
See, sir. So, Hammad, we are actually going over to Sakhar also. So they are connected with us.
Wonderful.
And there is a solitary resident over there, and she says that it's C.
Okay, wonderful. And she is so right. Okay, my third question is that when should a biopsy be done for a patient planned for thermal ablation? So you have decided that your patient is going to go for thermal ablation. When would you do the biopsy? First of all, there is no need for biopsy. You can do thermal ablation, a small lesion, you burn it and keep follow-up with the CT or ultrasound. You do biopsy at the time of thermal ablation, meaning that you put the needle, take a biopsy, and then put a RFA needle or a cryo needle and take care of the tumor. See that you do the biopsy, wait for the outcome, and then decide whether you would do a thermal ablation or not. So just consider the case that I've presented early on and answer the question.
So, yes, what should be the answer? Or what should be the latent period between your decision to do thermal therapy and biopsy?
See, sir.
See, sir.
It should be done
See, sir.
prior to that and wait for the pathology.
Okay.
Interesting. Let's look at the guidelines and see how you have answered these questions and which of them were correct. So if we look at the guidelines, there is low quality data suggests that disease recurrence after RFA for tumors which is greater than 3 centimeters is significant. So for RFA, the cutoff, according to the current literature, not a very good quality literature, is 3 centimeters. Anything which is more than 3 centimeters should not be treated by RFA, number one. Number two, for cryo, similarly, if you do cryo for a tumor which is more than 4 centimeters, meaning T1B cancer, then again, the chances of recurrence is significantly high. So you would not do cryo for tumors which are greater than 4 centimeters. This is answer to the question that they should not be, the size cutoff is different for the two treatment. So the in terms of comparison between cryo or thermal ablation versus partial nephrectomy, so far the data indicates that partial has a better oncological outcome, although partial nephrectomy is significantly more morbid, meaning that there are more complications in partial nephrectomy compared to thermal ablation. So if we look at the recommendations on management of such lesion, the active surveillance or thermal ablation is offered to frail and comorbid patients who are not good candidate for partial nephrectomy. So partial nephrectomy, oncologically superior, more complication. So if your patient is quite elderly, old, small tumors, then you would probably consider doing thermal ablation or active surveillance rather than partial nephrectomy. A percutaneous biopsy should be performed prior to, and Sakhar was right, that it should be done prior to the procedure rather than at the time of procedure, although it's slightly more convenient to do at the time of the procedure. But again, and I'll show you further details as we go along, that why it should be done prior to the procedure. When thermal ablation or active surveillance is offered, consider that patient understand the harms and benefits of treatment, and the decision is made on mutual consensus rather than your opinion. So, and do not offer thermal ablation for greater than 3 centimeters with RFA and greater than 4 centimeters with cryoablation. Now, if you look at the epidemiology of small renal masses, the incidence has significantly increased. And as I've said, that vast majority of patients now present, and in Western countries, over 80% of the tumors now present as an incidental finding on routine sonography and CT scan rather than discovered on clinical symptoms. Smoking, hypertension, and obesity are three factors which are clearly associated with renal cancer, and these are the so-called risk factors for kidney cancer. Although the relationship between these is not very strong, it's more of epidemiological data indicating the relationship between the two. Now, one interesting thing which has happened is that although we are detecting cancer early, we are obviously, when you're detecting, we are treating significant proportion of these cancers as well. We have not been able to decrease the death or mortality from kidney cancer. And I'll show you data that this has not happened. So there's some disconnect between our ability to diagnose and our ability to decrease the mortality, which is the final outcome of any intervention in patients undergoing cancer treatment. Okay. So I looked up the Dolan's famous medical dictionary to see what's a cancer. A cancer is defined as a neoplastic disease, the natural course of which is fatal. And this is something that you observe on a daily basis in the clinic. No sooner you have mentioned the word cancer, the patient becomes uncomfortable. They even start crying in the clinic, although not all cancers are the same. So cancer has a connotation of a fatal disease which will ultimately kill you before time. Now, what is the diagnosis of overdetection or overdiagnosis? Now, because we are started to detect tumors before they are symptomatic, we are detecting some of these tumors which probably would have remained undetected throughout the course of the life of that patient. And this patient may die from other causes rather than cancer. This is something we see very clearly in renal cancers. I'm sorry, prostate cancer, but the same is happening with the kidney cancers as well. So cancer overdiagnosis may have one of the two explanations. Number one, the cancer never progress. So although we have a cancer, this cancer doesn't progress. And this is something that is not known to us about 20 years back, when we always thought that cancer progressed. The second thing is that cancer progresses so slowly that the patient dies of other causes before the cancer makes its impact on patients' overall health, resulting in significant complications. So what has become important now, that the cancer size at diagnosis is important. Since we are diagnosing cancer early, we are diagnosing small cancer, and not all small cancers behave in the same way, number one. The cancer's growth rate is extremely important, and it is important that you also look at the patient. So a cancer detected in a 35-year-old male is different from a cancer detected at a 75 years of age, same size, same, because the comorbid condition, the natural course of patient's life may result in significant issues in a 35-year-old versus 75-year-old. So this is an interesting graph, and you can see that the newly diagnosed cancers have increased significantly in number, whereas the death rate is more or less stable. So this is from 1975 to 2005, and I'm sure that more recent data would also indicate very similar trends. So We are detecting more cancer, we're detecting early cancer, but this has not impacted on the overall outcome of cancer. Right, let's come back to another case. And this is somebody I saw very recently. One of my class fellow who works in US called me up and said that he wants to come and show his brother. And his brother is an engineer. He was visiting US, got some vague abdominal pain, particularly GERD-like symptoms, got an ultrasound, and ultrasound showed something funny. He is a controlled hypertensive. He doesn't smoke, slightly obese with a BMI of 29.5. And his younger brother, who's my class fellow, is who's a physician, had a radical nephrectomy for an RCC some years back. And this is his ultrasound, and you can see a space-occupying lesion in the middle pole of this kidney, and subsequent CT scan showed that there is an enhancing neoplastic lesion in the midpolar region of the left kidney, which is enhancing with areas of necrosis in the middle. Very typical kidney cancer, and this is what he has. So the first question was that, are kidney cancer genetically transmitted, or is there a genetic disorder which can result in kidney cancer? And my question to the audience is yes, raise your hand, no, keep the hands down.
So what do you think? Yes or no? Yes. So overwhelmingly, they are saying yes.
Wonderful. You've got very learned residents who know everything, to be honest. So indeed, kidney cancers are related to, they are related to various syndromes, various conditions which are hereditary. And some of the well-known ones is VHL or von Hippel-Lindau disease. I think all of you know that. Then there is hereditary papillary renal cell carcinoma syndrome or genetic predisposition. The TSC, which is also known for angiomyolipomas, more commonly known for angiomyolipoma, but they can also result in renal cancers. And the Bit-Hogg-Dube syndrome, a relatively rare condition, but they are genetically transmitted. So in cases of VHL or von Hippel-Lindau disease, they could be hemangioblastomas of brain, spine, and retina, various lymphatic tumors of the central nervous system and the brain. And they're also associated with bilateral renal cysts. They could be associated with cystadenomas of the epididymis and so on. So von Hippel-Lindau disease has many urological manifestation, and including pheochromocytoma and renal cell carcinoma. The recommendation is that patients with von Hippel-Lindau disease should be, clear cell carcinoma is the predominant cancer that they have. Active surveillance is recommended for tumors which are under 3 centimeters, and if the tumor grows in size, then active intervention should be done, preferably partial nephrectomy. The HRPC, which is the hereditary papillary renal cell carcinoma, it doesn't have any extrarenal manifestation. It is on MET's gene. The papillary type 1 RCC is the predominant tumor. And again, the recommendation for treatment or intervention is a cutoff of 3 centimeters. So these are easy to remember, 3 centimeters for the residents appearing in exam, that the cutoff in this situation is 3 centimeters. The TSC, which I have said is associated with renal cyst, with hemangiomyomatosis of the lung, facial manifestation, angiofibromas, the TSC complex, which is very commonly known, the facial adenomas, angiomyolipomas, etc. It can give rise to various types of renal cell carcinomas and the angiomyolipoma. And the recommendation for angiomyolipoma is to try and treat them conservatively for smaller ones, embolize them if they are greater than 3 centimeters, and resect them if they are even bigger. Same recommendation for RCC as well. Bit hog tube, again, relatively rare. It is associated with hybrid oncocytic renal cell carcinoma or chromophore tumors. So when you see chromophore tumor, you should look for other manifestations and see if there is a possibility of bit hog tube. And then the patient's family should be counseled for close monitoring to see if any other family member is undergoing similar changes. And these are some of the other rare ones. I'm not going to go into the details. So hereditary RCC is a well-defined entity, and you should suspect that if the patient presents at an early age, and early age means between 30 and 50 years of age. If the single gene testing is what is recommended for other family member to find out if they have similar genetic defects so that they can be counseled and monitor actively. Patients often presents with bilateral tumors and chances of recurrence is high. So it's important that they should be managed as conservatively as possible, but again, not compromising the oncological control, which means that you have to treat them so that you preserve kidney function, so that they don't end up being on dialysis, and also do not leave them too long so that they develop a metastatic disease when they become, it's very difficult to treat. We know RCC when it becomes metastatic. So nephron-sparing techniques like enucleation is recommended. So you preserve as much parenchyma as possible by doing enucleation rather than enuclear resection or wedge resections. Aggressive approach for tumors which have a high likelihood of metastasis. The long-term renal functional control is extremely important. Now, remember that if you think that partial nephrectomy, if performed for a small renal cancer, has good oncological outcome and it should be done in all patients, remember that whenever you intervene on a kidney, you actually cause some damage, and this damage can result in long-term functional disability. So this is an interesting paper by Brian Shook, and they have looked at control versus patients with kidney cancer managed by either partial or radical nephrectomy. And in both situations, you can see that there is a significant difference in the renal function impairment between those patients who did not have a kidney cancer surgery versus those who had kidney, and both partial and radical can result in significantly more chances of ESRD rather than those who have not been treated in similar fashion. This is a very similar paper by Guyan et al. Presented in Urological Oncology a few years back. And you can see in the graph, the blue is representing the renal malignancy, patients with renal malignancy. And this is development of new end-stage renal disease. Whereas green are those who have traumatic surgical loss, be it from surgical intervention for benign diseases or trauma like motor vehicle accident, etc. And benign kidney tumors like oncocytoma or angiomyolipoma or some other adenoma of the kidney. So if you look at the three, there is significantly higher chances of development of end-stage renal disease in patients who have had a renal malignancy treated rather than had any other benign intervention on the kidney. benign disease of the kidney. Again, this is a very similar data coming from Michael Jewett et al., very famous urologist. And they have also looked over a period of time the development of kidney dysfunction in patients who have tumors, those who have biopsy-proven tumor, and those of benign tumors. So all of these have significant incidence. So essentially what I'm saying is that patients who have got kidney tumors and who have had an intervention for kidney tumor are at risk of developing end-stage renal disease. So be very mindful of the fact that are you going to cause functional impairment by treating this patient, or you can follow this patient without intervention. So these are very important questions and they should be made early. And I'm going to talk a little bit further to see how those decisions should be made in a scientific manner so that you don't compromise cancer control. So when we treat cancer, the patient may ask, जी क्यों आप इसका इलाज करना चाहते हैं? जी इतना छोटा सा ट्यूमर है, उसका इलाज इसलिए करना चाहते हैं कि it can metastasize, and once it metastasizes, it's an inoperable condition. So that's why we want to intervene. So the question is raised in this data that if you have a tumor which is 0 to say about 3 centimeters, the chances of metastasis is almost 0%. So if your tumor is less than or equal to 3 centimeters, it is not likely to metastasize. If the tumor size is between 3 and 4 centimeters, there is about 1.5% chance of metastasis. It is only the tumor which exceeds the size of 4 centimeters that the chances of metastasis starts to increase significantly. And as you can see, that 2.5% to 5% to 6% chances of metastasis for tumors which are up to 7 centimeters. So even up to 7 centimeters, there is only a 5% chance of metastasis. So remember that the metastatic potential of a cancer is number 1 related to the tumor size. So that's an important point. So now coming back and looking at all that size and hereditary factors and intervention resulting in problems, how do you make a decision for a small renal cancer? Number 1, you look at the patient factors, and the patient factors include comorbid conditions. So is your patient going to die of his cardiovascular diseases or his neurological diseases or his pulmonary diseases, or is he going to die from the cancer? If he is likely to die from concomitant pathologies, then don't treat the cancer. The patient's quality of life and socio-economic aspects also important, and the baseline kidney function. So these are patient-related factors on which you will make a decision whether this patient should be actively treated or the patient should be on active surveillance. Now, the other important thing is that besides patient, and all of you have answered D to the first question where all these factors are important, but right. And this is the greater description of that question, that there are tumor-related factors. And we have seen that size is an important factor as well. So tumor-related factor include the size, the tumor complexity. If you have prior imaging, so 1 year back, the tumor was 2.2 centimeters, and now it is 2.4 centimeters. The size increase is minimal, and this patient can be observed for another 2 years without significantly increasing his or her chances of metastasis. Right? Is that clear? Now, another factor that I'll talk a little further about is the tumor characteristics as well. And there are certain types of tumors which have a greater potential for the same size to metastasize than the others. So these are tumor-related factors, and we are going to come to those factors as well. So when we are into those decision-making thing, we need to see whether once we have seen the patient and this patient require either active surveillance or the patient requires expectant management. If we have decided because of the comorbid conditions, because of low potential for metastasis, the patient is not likely to be treated actively. So you decide for active surveillance and expectant management, and like prostate cancer, very similar protocols. So for active surveillance, you are actively following the patient so that if he or she develops progression of disease, you would intervene. So every 3 to 6 months, you're going to image the patient and see if the patient's tumor is progressing. For expectant management, once or twice a year, you're going to do imaging to see the progression of disease. When would you intervene? For active surveillance, if the tumor size increases to greater than 3 centimeters, the tumor progression rate is greater than 5 millimeters per year. So if the tumor increases the size for more than 5 millimeter every year, then this patient is likely to develop a more aggressive cancer in the times to come, and one should start thinking of intervention.
Hammad, can you, for our junior colleagues, can you explain the difference between watchful waiting and active surveillance?
So expectant management or watchful waiting is to intervene only when the patient tumor is likely to kill him. That is, if it is developing metastatic potential or metastasizing. Whereas active surveillance is that you actively looking at patient, and for this you require a very religiously follow-up of the patient, and you are actually looking for any signs of disease progression. So active surveillance is looking very closely to find disease progression and intervene before it becomes too big. Expectant management is that you would like to give patient an opportunity of not doing a surgical procedure or intervention so that his quality life is not affected, and only intervene if this tumor is going to kill the patient before he dies of some other cause. I hope this is clear.
Yeah, because this is not synonymous, and this should be very much clear in everybody's mind.
No. This is the two very different things. Same for prostate cancer, some minor differences. For example, in prostate cancer, you'll have to do a biopsy every year, because not only the PSA is important, but also the fact that your biopsy show that the Gleason from 7 has become 8. So if the Gleason was 6 or 7 at the initial time when you've decided for active surveillance, and next year, if you do a biopsy and the Gleason becomes 7 or 8, then you would intervene. Similarly, if the MRI scan showing pyrite 4 becoming pyrite 5, then you would do active intervention. So slight differences in terms of, but basically the concept is very similar, that active treatment or active surveillance and expected management are two very different entities. The other important thing is that when we were medical students and when we were in the earlier year of our training, kidney cancer biopsy was considered as a big no. Kidney cancer की biopsy नहीं करते भाई. उसकी वजह ये है कि वो कैंसर फैल जाता है, ट्रैक के अंदर चला जाएगा, आप रास्ते में ट्यूमर गिरा देंगे और स्टेज 1 ट्यूमर जो है स्टेज 3 ट्यूमर और 4 ट्यूमर बन जाता है. So this was a norm until very recently, about 10-15 years back. But now you've got coaxial needles. You have got special biopsy needles in which the core of the tumor is removed from an outer sheath. And the sheath stays in the kidney, and you remove the tumor within a metallic sheet, rather than you take a true-cut biopsy and bring the whole needle outside and leaving a potential for a tract seedling. This doesn't happen now in the modern day biopsy, and modern day biopsy is an important way of making a decision whether your patient requires active treatment or not. So remember, why biopsy is important. Most small renal tumors are indolent, meaning that they're not very aggressive. Also remember the fact that for very small renal tumors, about 80%, only 80% are malignant. Not every solid renal tumor is a malignant neoplasm. So that's why if you do thermal ablation without biopsy, you may be ablating something which is not even cancer. So that's why biopsy is important. And biopsy becomes important because 20% of the renal tumors are benign in that size group. Often I've identified these tumors in elderly people with comorbid conditions. So it's important that you first decide whether it's a tumor, an aggressive tumor, which has a potential to metastasize and can cause significant problems, and only then intervene. So renal biopsy has become, in the modern armamentarium of kidney cancer management, an extremely important tool in the evaluation and management of disease. So it is safe, and it is, but it does have some element of complications. Hemorrhage is a very frequent thing, and that one should be very careful. And I think you guys have a great experience in doing kidney biopsies for nephrological diseases, but you do see complications as well, and same can happen for kidney cancer. So let's look at the algorithmic way of when the biopsy be done. So when you see a CT scan or an ultrasound or an MRI scan, and there is a suspicion of a small kidney mass, and this mass can be an abscess or a lymphoma, then you would not do a biopsy. So you would do a biopsy to make a proper diagnosis of what this is. Is it a lymphoma? Is it some benign tumor? Or is it an RCC or renal cell carcinoma? If you don't suspect that, the second question that you will ask, is this patient for active surveillance? That his or her comorbid conditions do not allow to intervene. So if yes, then do a biopsy so that you know that you're dealing with not a very aggressive cancer. And if you have decided to active surveillance, your tumor is not very aggressive, you can continue with active surveillance. If no, that patient is not for active surveillance, and if the tumor is identified to be cancer and malignant and likely to progress, then you do a biopsy to make sure that you are either planning for ablation of the tumor, or you're planning for some form of kidney cancer surgery. So if the ablation is planned, do a biopsy before you ablate the tumor so you know how to follow these patients. If the patient is either not fit or is not willing to observe a benign lesion, then again, biopsy be done. So these are the various questions that, and obviously you don't, when you are looking at a patient in a clinic, your mind works and you have to train your minds and able to ask these questions in your mind when you're seeing a patient and make the decision, how would you go next? And this is the artificial neural network. You keep reminding yourself with these questions, and then it will become your neural network. Now,
So can we say, sorry.
Yeah,
So can we say that biopsy reserved only for those who fall into the category of SRM, or is it something that, for instance, has got a question mark as regards a renal mass, whatever the size of the mass may be? So can we say that?
Yeah, so since we had only talked about small renal masses today, so I've not touched upon larger tumors. So what Dr. Asad is asking is that if you have a big tumor, is there an indication of biopsy? Yes. if you think that this tumor could be anything but RCC, so it could be anything, any other tumor. Recently, I've operated on a big upper polar renal mass, which on imaging looks like a renal mass, but actually it was a very aggressive adrenocortical cancer in which all the anatomy was disturbed and the adrenal gland was not clearly visible, and it has invaded the kidney. So it looked more like an renal cancer rather than adrenal cancer. And only it's after biopsy pathology that we come to know that it was. In a situation like this, you would do biopsy, you can be more wiser in devising treatment. Sometimes your kidney cancer is so large or set that you don't know whether it is you are going to do a cytoreductive nephrectomy or you're going to do some form of systemic therapy first. So if you do some systemic therapy first, you need to see if it is clear cell carcinoma or it is some other form of renal cancer, because the management using various systemic agent is very different for different types of cancer. So it is important to know maybe if there is a suspicion of a lymphoma rather than a tumor, all your treatment would be. Sarcomas and various types of sarcomas can also mimic kidney cancers. So in all that situation, biopsy becomes imperative in the management of these patients. So coming back to the importance of biopsy, because we know size is a significant factor in making decision, but size is not the only factor. There are certain adverse pathological features which have shown to be conferring more aggressiveness to the cancer than those patients who do not have these adverse pathological features. And these includes the sarcomatoid or rhabdoid features, and they could be sometimes rhabdosarcomas or pure carcinoma plus sarcomatoid cancers, and so on, various combinations. Lymphovascular invasion, we know that patients who have lymphovascular and perineural invasion are at a greater risk of metastases, presence of coagulative necrosis, high-grade cancers, if there is an involvement of the sinus fat, and if there is a type 2 pathology, papillary type cancer, again, they are very aggressive cancer, and type 2 papillary are sometimes seen in various hereditary cancers, as we have seen previously. So these are some of the important adverse pathological features, which if present even in a small cancer, which is under 3 centimeters, require that you need to be more aggressive in your treatment. So the question is that these are related to size, so which means that does very small cancer can also have adverse pathological features, or it is only bigger tumors like 2.5 to 3.5 to 4 centimeter tumors who would have aggressive pathological features? So let's look at the data. So the question is that can even a small cancer like a 1.5 2 centimeter cancer also have adverse pathological feature? And this is an important, interesting work by Schulman and colleagues. And they have seen that the presence of adverse pathological feature in a tumor which is 1 or greater than 1 centimeter is about 20%. And as the tumor size increases, the chances of these adverse pathological features continue to increase in size, increase in percentage. So for a 3 to 4 centimeters, there is about 55% chance of presence of adverse pathological feature. And that's why greater than 3 centimeter tumors are likely to metastasize. And this is the data from the same work indicating the relationship between size and death. And if you look at 1 versus more than 1 adverse pathological feature, then again, the Kaplan-Meier curve is showing that the outcome is very different if you have more than 1 adverse pathological feature. So if you have 2 other adverse pathological feature, you're more likely to die of the cancer rather than if you have one. So, so let's come to some form of conclusion from whatever we have discussed so far. So if you have a newly diagnosed, clinically localized solid renal mass, a small renal cancer, your decision point number one is that is this patient going for active surveillance, or the patient is going for tumor treatment? So you have to make that decision first. Once you have made a decision that the patient is going to be treated, active surveillance का आपने decide कर लिया, size, pathological features, biopsy features देख के, मरीज की comorbid conditions देख के, and then वो फिर एक patient active surveillance पे चला गया. If you have decided that this patient requires some form of active treatment, then it is either thermal ablation or partial or radical nephrectomy. This is the decision point number two, that you have to decide which is more appropriate. The decision point number three is that if the patient is going partial or radical nephrectomy, whether it's going to be open surgical procedure or a minimally invasive surgical procedure. And then we're going to touch upon do I have 5-7 minutes more, Asad?
Yeah, you can take your time.
Okay, thanks. So coming back to active surveillance, remember that small renal tumors, meaning less than 3 centimeter tumors, have a growth rate of only 0.5 millimeter per year. So unless they are associated with some adverse pathological features, they have a low growth rate of 0.5 millimeter per year. How to follow them? You need to look at the size very critically, and it's important that the same radiologist look at those, or there is a standardized way of calculating the size of the tumor so that everyone talks of the same language. The velocity of change, meaning that the increase in the size over a period of time, is also important. Aggressive tumors grow rapidly, like prostate cancer. Less aggressive tumors would be like 0.5 millimeter per year kind of growth rate. So if your 2 ultrasounds or 2 CT scans have shown that the growth rate is lower side, then this patient is likely to do very well with active surveillance. If you look at the outcome for active surveillance, remember that about 1 in 10 patients would have radiological progression. And about 93% would not show a change in their overall behavior in terms of aggressiveness, metastatic potential, etc. And about 1/4 of the patient can have delayed intervention without any adverse outcome. So rather than treating today, you may treat them a year or 2 years later, and again, your patient would have the similar outcome. So all in all, active surveillance is not a bad decision in select group of patients, but you have to make those decisions wisely.
Hammad, I would like to have your a few more sentences about this technology, CEUS.
Okay, so CEUS is the contrast enhanced ultrasound. Now we know that ultrasounds are ultrasounds, which is grayscale ultrasound, the duplex ultrasound, and duplex ultrasound is slightly more superior because duplex ultrasound can also show you flow, and new angioneogenesis is an important feature of RCC. So, but then there is a third modality now, which is the contrast enhanced ultrasound. And contrast enhanced ultrasounds have shown in good hands to be equivalent to contrast CT. So you introduce microbubbles and then you do ultrasound, and your images and pictures are as good as that of a contrast CT. The advantage of contrast enhanced ultrasound, particularly in patients who have got compromised renal function, is that you don't need to give radio contrast, the contrast pharmaceuticals, and that can significantly impact the overall outcome, because these patients are going to require regular 6 monthly CT scans, contrast CT scans. So if you do CEUS, which is contrast enhanced ultrasound, rather than a CT, they are going to have greater preservation of their kidney function, because contrast can result in various kinds of nephropathy. Contrast using an MRI scan, which is gadolinium, can give systemic fibrosis, which is a pretty irreversible kidney damage. So that's another big thing, that if your patient has compromised renal function, you do MRI scan with gadolinium, these patients are going to have nephrogenic systemic fibrosis, or NSF, and that's an irreversible kidney damage. Whereas contrast nephropathy secondary to the CT contrast is relatively less, but it still has the potential for.
Right, because why I'm stressing on it, just because of the fact that you have mentioned the radiation dose and the fibrosis that is caused by gadolinium. The thing is, it has been proposed, and if we can draw an analogy from prostate cancer, in the recent ASCO, they have proposed this thing as part of their guidelines, CEUS, as in comparison with results from multiparametric MRI for prostate cancer. So maybe this technology in the recent future can be something which is, since it is mobile, since it is portable, it is cheaper as compared to multiparametric MRI. And since our region hasn't got that kind of economic backup, this thing has got a potential for us in many different kind of pathologies.
Yeah, I mean, indeed it is. But one of the things that we need to remember, and this is something that you confront on a daily basis, is the ultrasound has one little problem, that it is so operator dependent. So if you have a good operator and you do contrast enhanced ultrasound, it is, you're absolutely right, as good as an MRI scan or as good as a CT scan with contrast. Okay, so a few words about ablation therapy. Well, cryo and RFA are the two commonly used. We have experience of RFA, not much, and microwave thermotherapy rather than cryo. We don't have cryo. So essentially, a very select group of patients can have this treatment. One of the problems with these treatment is that it cannot be done if the tumor is close to the collecting system or major vessel, because these become the heat sinks. And in order for cryo or thermal therapy to work, it has to be done up to a certain optimum minus 40-degree temperature for cryo, and greater than 70 degrees for RFA. So, but if you have a vessel close by, it provides a heat sink and it takes away the heat and can also cause damage to the vessels. So there are certain limitations to these treatment, but they are good for very ill patients who've got potentially aggressive cancers. So these are some of the pictures. We don't need to really go. And for the benefit of time, I'll just go on to the question that we have raised at decision point number 3, which is open versus lab and robotic, mean MIS, partial nephrectomy versus the open partial nephrectomies. So this is the data from the European Association guidelines. And if we look at the partial nephrectomy, open versus minimally invasive partial nephrectomies, the 5-year follow-up is the same local recurrence and distant metastases and other cancer-related changes in partial nephrectomy done by open. So oncologically, one is not superior to the other, provided that it is done by a person who is able to do a good job. So if Asad can do a wonderful open partial nephrectomy, and Rehan can do a wonderful robot-assisted partial nephrectomy, the outcome would be, oncological outcome would be very similar. The perioperative outcomes are slightly different between partial and robot-assisted procedures, and particularly the short-term outcomes. If you look at the long-term outcome, there is hardly any difference. So robot-assisted and EOE guidelines conclude that robot-assisted and lap partial nephrectomy are associated with shorter hospital stay, lesser blood loss compared to open partial nephrectomy, and that's there's no doubt about that. So partial nephrectomy is associated with higher percentage of positive surgical margin compared to radical nephrectomy, which is obvious thing. And hospital volume is more important thing than the technology. So open, lap, partial, important thing is that how much you are doing it. So irrespective, if you're doing 2 partial robotic nephrectomies a year, there is no point doing it robotically. So you do whatever is more commonly done at your place. If we compare laparoscopic versus open partial nephrectomy, again, the data indicate there is no difference in in the progression-free survival and overall survival. The mean blood loss is slightly less than in partial perioperative. So basically, the operative time is longer for lap partial nephrectomy. It's a technically demanding surgical procedure, and warm ischemia time is shorter with open approach. So if you're really good with lap pilos, lap partials, then it's fine. But if you are still in the learning curve, it's best that you do an open and have a good outcome rather than doing a minimally invasive procedure. Open versus robot assisted, again, the data is not very convincingly showing that robot assisted procedure have any superiority over except for shorter hospital stay and less blood loss. Okay. Now I think we can skip some of this. Okay, so this is an important slide. What are the factors which influence preservation of renal? Because, you know, the whole idea of doing a partial nephrectomy and really making your coronaries contract and become atherosclerotic during that surgical procedure rather than doing a straightforward radical nephrectomy, is that you want to preserve the kidney function. So what are the factors which influence kidney function in a person undergoing a partial nephrectomy? And most important thing is the preoperative kidney function. So if you have greater than or equal to 45 ml GFR, there would be significant difference in the overall preservation of renal function after partial nephrectomy. The quality of parenchyma preserves. So if you have followed the principle of 25 minutes warm ischemia time and various techniques of arterial versus arteriovenous versus no clamping partial nephrectomies, it does have a significant impact, because whatever insult we make to the leftover parenchyma is going to determine over a period of time what will be the outcome. So if you do an off-clamp partial nephrectomy, again, the preservation of the leftover parenchyma would be better than anything else, and it is really ideal. But it's not possible to do off-clamp nephrectomy. And when I say off-clamp nephrectomy, what I mean is that either you do arterial-only clamping, you do arteriovenous clamping. When you do arterial-only clamping, then you would allow some venous backflow perfusion of the rest of the parenchyma. If you do only partial clamping using manual clamping around the tumor site without clamping the renal vessels, then you would be much better because the rest of the parenchyma is continuously perfused. So this is off-clamping partial nephrectomies, and they would have a better renal preservation. So we know the trifecta for partial nephrectomy, and this is one of the chapters I've written in this book published from London a few years back. The trifecta is that there should not be any major complication. There should be negative surgical margin, and the warm ischemia time should not exceed 25 minutes. So these are very standard 3 principles of doing a partial nephrectomy. And if you do that, you have achieved the trifecta. The pentafacta is that there is greater than, besides 3, there is greater than 90% preservation of the eGFR. So if your eGFR is 50 prior to partial nephrectomy and it is 46 after partial nephrectomy, you have greater than 90% preservation of the GFR after the procedure. So this is the 4th point in pentafacta. And the last point on pentafacta is that there is no stage grade of no stage migration of the CKD at 1-year follow-up. So these are the principles, and if you follow these principles, you would be doing a fairly good job, and you will be able to achieve a wonderful outcome after partial nephrectomy, that you have made the tumor, excised the tumor, so good oncological outcome. And then you will also preserve the renal function, so you have good functional outcome as well. And just for the sake of our junior colleagues, you remove the tumor either as enucleation, which means that you remove a nicely encapsulated tumor, and I can show you a few videos, or you do enucleoresection, which means that you remove a little rim of parenchyma around the tumor. So you define a plane, remove some of the parenchyma along the tumor. This is called enucleoresection. Or you do traditional resection or wedge resection, in which you remove significant portion of renal parenchyma along with the tumor, so that you can have negative surgical margin. So these decisions are fine, and it depends upon your experience and your ability to plan your surgical procedure using the preoperative imaging and peroperative findings when you do that. And you can do it, most of the time you end up doing, what I end up doing is enucleoresection, but sometimes for small peripheral tumors I also do, and particularly if the capsule is very well defined, and you can send biopsies, frozen section biopsies from the bed, that enucleoresection will, the enucleation will preserve the parenchyma the most, enucleoresection in the somewhere in the middle, and the wedge resection, significant loss of parenchyma. Not only it's the part of the parenchyma which is taken away, takes the renal function away, but also the fact that in order to do a wedge resection, you would have greater parenchyma which is exposed in bleeding. So you would take a little longer in reconstruction, and then you would take deep bites in order to control the hemorrhage. And in that, you will also lose some parenchyma.
So, Hammad, what's your personal preference? Would you like to have frozen section for knowing your negative surgical margin, or would you like to prefer doing a peroperative ultrasound to know the actual interface?
Right. So it's ultrasound I find only helpful in very deep tumors where it is really difficult to define the margins of the tumor with the renal sinus fat or collecting system interfering, or for irregular tumors. But in vast majority of mostly exophytic or part exophytic endophytic tumor, I don't need to do either an ultrasound or a frozen section. And I would say that about less than 1/4 of my patients have frozen sections during surgery, although we have frozen section standby all the time. So at the end of removing of the tumor, decides whether frozen section is required. Sometimes you do it because the patient's family wants to have it done. Sometimes you also feel uncomfortable that tumor may have some tumor may have been left, or your tissue that you're seeing in the bed of the tumor looks suspicious, and then you send it for pathology. So the very simple principle of the renal vasculature is known to all of you. And these are the kind of tumors which are really bad cancers. And there, as Professor Asad was mentioning, the use of peroperative ultrasound in order to define where you're going to cut. So ultrasound is not only used for surveillance and monitoring of the periphery of the tumor and extent and depth of invasion, but also where you need to cut. So for partly exophytic tumor or palpable tumor on the kidney surface, it's really easy that you feel the tumor, you take a rim of parenchyma or don't take a rim of parenchyma and you excise the tumor. Whereas deep-seated tumors, you don't know where the tumor are. Just like in the olden days when we used to do nephrolithotomies, that you don't know exactly where the stone is and where to make your nephrotomy. Similarly, in a situation like this, in order to isolate the tumor, ultrasound is invaluable. And again, once you've resected, then you can scan the area. And if you're good with ultrasounds, you'll be able to see that there is no leftover tumor. So, yeah, I mean, for tumors like this, I think partial nephrectomy is, although these are T1B at the most T2 tumors, no, partial nephrectomy is really very, very challenging unless there is a imperative, an absolute indication of partial nephrectomy, which means that the contralateral kidney is also poor. I would not probably go in and do a partial nephrectomy for tumors like this, and rather than do a radical nephrectomy, because the primary thing is to be able to do a good oncological control of the disease, rather than be a hero and do a partial nephrectomy for such cancers. So I think I'll stop here. I've already crossed my time limits because I would have some more slides about the technique of partial nephrectomy, but I think that's not very important. So I'll be happy to take if there are any questions.
Yeah, so we open our forum for discussion and questions. Please, yes. So Madharis wants to pose a question.
Sir, excellent presentation, and we have learned a lot from it. I have got a query that if a patient who has got no comorbids and approximately 40-50-year-old with a small renal mass of 3 centimeter or 4 centimeter, so will you offer that patient active surveillance, or it is only for those patients who have got comorbids or they've got some problem?
So greater than 3 centimeters, if the patient does not have any significant conditions which precludes use of intervention, I would not offer active surveillance. So I would offer active treatment to these patients. If they are fit, they are 45-50 years of age, they do not have significant comorbid conditions, and the tumor is greater than 3 centimeters, because we have shown that anything which is more than 3 centimeters, it's very likely that they would develop metastatic disease in about 10 to 20% of cases. So I would probably be more aggressive in this fit person rather than giving them active surveillance.
And sir, if it is less than 3 centimeter, then will you offer that patient active surveillance?
So that's a difficult question. And I think this is the point where biopsy becomes important. So a fit patient with a normal functioning contralateral kidney, no significant comorbidities, tumor less than 3 centimeters, I would biopsy that patient to make sure that he has an RCC, number one, Number two, that his RCC contains any adverse pathological features or not. And if he or she doesn't have any adverse pathological features, if it's an RCC, and if it is a clear cell carcinoma and not papillary type 2 cancer or a rhabdoid, then I would offer them active surveillance as one of the options, provided that I understand that they would be very clear to follow up regularly with imaging in 3 to 6 months' time.
Thank you.
Yes, Bilal.
Thank you for the nice presentation, and we are really happy here to be learning from you. My query regarding is about the microinvasion. Is this a characteristic of these renal cell carcinomas, microinvasion? Because if it is there, then we have to have frozen section while we are doing partial nephrectomies. If there is no microinvasion in these renal cell carcinomas, then do we really need these frozen sections while we have macroscopically, visibly removed all the tumor?
So when you are operating and you see these tumors, you know that you have removed a well encapsulated kidney tumor, or you have removed with some rough areas. And in a situation where the capsule breach has occurred and it is visible or palpable, I would definitely do a frozen section. In my experience, in the reported experience, vast majority of tumors which are suitable for partial nephrectomy are well encapsulated. So essentially, in the earlier part of my career, I was doing a lot more partial nephrectomy, lot more frozen sections, but now I do very infrequently, and every third patient would not have a frozen section out of 4. The second important point about the kidney cancer is that, and this is something that was discussed a couple of months back in the Eurocon in Islamabad as well, and I was asked this question about positive surgical margin. So what if your frozen section is positive? Would you go in and do another frozen section? And you may sample the right, may not sample the right area, and you might find a negative section with the positive surgical margin, or you would do a radical nephrectomy in that patient. Now, this becomes a question, and this has been addressed in literature, that positive surgical margin is not associated with very significantly bad outcome. It's not that you should breach the tumor or you partly or half cut the tumor when removing it, but if you have removed the tumor and there is one little spot of positive surgical margin, that would not mean that you would require either systemic treatment or radical nephrectomy at some other stage. So you can observe these patients, and they are like very tiny foci of kidney cancers, which will grow very, 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 very slowly. So you can still watch them and be on surveillance rather than active management. So that's why, for all these reasons, frozen sections are not very commonly performed in the practice of those who are doing significant numbers.
Yes, sir, Madhu sir.
Thank you very much for this excellent lecture. I fully enjoyed this, and it was a pleasure to hear you. Just one or two queries that do you see von Hippel-Lindau disease here in Pakistan, and how will you treat these cases? VHL.
We have not been able to do genetic mapping, but as I was talking about earlier on in the presentation, I recently had a colleague whose brother had a RCC, and he is likely to have a VHL. We have seen many patients with VHL with all the manifestation of the VHL, So we have made clinical diagnosis on these patients. And one need to be very, very vigilant in treating, because it's so easy to make a decision of removing the whole kidney or doing multiple partial nephrectomies. But the functional outcome and the quality of life is very poor in these patients compared to if you are doing active surveillance for small tumors. So the cutoff is 3 centimeters. If you have less than 3 centimeter tumor, you can observe them closely and they would not progress significantly. If you have greater than 3 centimeters, try and do enucleation rather than enuclear resection or wedge resection, so that you leave significant parenchyma, because it's very likely that you may have to go in again and do a partial nephrectomy on this patient 4 or 5 years later. So very close monitoring is extremely important in this group of patients.
Thank you. And how do you treat the recurrence after partial nephrectomy?
Observation, sir.
Observation.
Yeah, for small foci of tumors which have appeared in your imaging subsequently, or you have a positive surgical margin, you do close monitoring and imaging, inform the patient that they need to be on close surveillance for the first 2-3 years. 3 monthly imaging of good quality is what is required. After they have passed 3 years, again, you can move on to 6 monthly imaging.
Thank you. Thank you.
Right. So Madhusa, just to add to the knowledge of everyone, we have got our own genetic lab in SIUT, Qasim Mehdi Genetic Lab, and Dr. Aisha has got a paper on the genetic makeup and workup of few of these patients who land up in our unit. And if I remember correctly, that paper is published, and I can share with you. We have got like not many cases, but maybe 10 to 15 cases were reported with a complete workup. Hammad, if you have got time, we have got 1 or 2 more questions.
Yeah, I'm okay. Please go ahead.
So, Usama.
My question is about the local treatment. If we are offering a local treatment like cryo or HIFU, so how about we sure about success of its treatment? Are we seeing it in a real time, real images? Like in open, we can see closing section, or biopsy, we can do later. So how about sure about in local success of the local treatment?
So since I wasn't able to hear the question clearly, the voice was not very clear. But what this gentleman is asking, Osama is asking, is about the thermal ablation and frozen section. Is that right?
No. He was asking that whenever you are doing cryotherapy or radiofrequency ablation,
Yeah.
do you have the real-time imaging available to you at which point the treatment is completed, or is it something which is done and then you can follow these patients later?
Okay, so now it really depends upon what kind of tumor you have. So majority of these patients either have percutaneous procedure, which is in ultrasound guidance or CT guidance. So the advantage of ultrasound guidance is that you have ongoing or real-time imaging continuously during the procedure. But for CT guidance, you have the needle in the right place, and then you monitor them. It's like old style lithotripsy, that you do CT, you put the needle into the right place in the middle of the tumor, you start your cycles, and you do a little shot after X number of treatments, and then you see that your needle is still in the right place, and if there is any significant tumor around in that area. So I'm not a technical expert in this, because in our department it is being done by the radiologist, but whatever a little I have observed, this is, and what I've read, this is what the treatment protocol is. Ultrasound gives you fairly good idea of continuous monitoring.
Thank you, sir.
Right. So another question. Yeah. Man at the back.
So my question is very simple. First of all, thank you so much for the excellent talk, sir. And my question is very simple. If a fit person with both kidneys, a normal function kidney and a tumor in one kidney less than 2 centimeter, what is the ideal recommended treatment for that? Either we should go for the cryo ablation and thermal ablation, or we should opt for the partial nephrectomy. What are the recommendations about treatment?
Okay. Okay. So remember that whatever the guidelines are there, whatever the recommendations are there, they are based upon generalization of certain facts. But when you are dealing with an individual patient, and that's why I've talked about so many things, the clinical conditions, the pathology, the adverse pathological features, patient age, comorbid status, your ability to do something, the availability of various armamentarium in terms of thermal ablation, etc., the probability of thermal ablation being successful if it is a peripheral tumor and versus it is more central tumor. So that all these factors have to be working in the back of your mind. And based upon this, you make a decision. But the most important thing is, and I tell them all these patients that I'll explain to you the whole thing. I'll tell you the complication of one versus other. I'll tell you the outcome of one versus other. You have to make a decision. So for the same tumor, for the same patient, one patient make a decision of going for an oncologically superior method, which is partial nephrectomy. There is no way that thermal ablation would be as good as partial nephrectomy. And the second step is that the second patient may decide they want as minimally invasive thing as possible. Now, important thing is that once you have decided that this patient require active surveillance versus active treatment, and if he requires an active treatment, you have to make a decision whether that active treatment is partial or thermal ablation. Thermal ablation is for small tumors suitable for thermal ablation and in patients who are not fit to undergo partial nephrectomy. Oncologically, partial nephrectomy is far superior to any form of thermal ablation. I hope I've answered your simple question.
Yeah, it was too simple. Yes, the last question.
Good evening, Dr. Hammad. Always a pleasure, sir, listening to you. Sir, just moving on from your previous statement. Now, if you do have a small renal cell, say about 3 centimeters, but the biopsy has very aggressive pathological features. Now, how will you decide between, say, a partial nephrectomy or a radical nephrectomy, keeping in mind that has very aggressive pathological features? Would you leave it to decide on the patient, or where you have one the patient's wishes and one you have oncological control on other hand, and what are the chances of recurrence in such a case in partial nephrectomy?
Now, one of the older myths was also that partial nephrectomy should not be done because there is a possibility of microsatellite small cancers in the rest of the parenchyma, right? And this is something that I have been told and I have learned as a trainee over 2 decades back. Now, this is no longer true. The outcome for all cancers which are suitable for partial nephrectomy is oncologically equal to radical nephrectomy. So if there are adverse pathological features, and if you have completely removed and you take frozen sections from the bed of the tumor and they come out negative, you have done as good a job as a radical nephrectomy. So your oncological outcome would not be compromised. So I would, for a 3 centimeters with 2 adverse pathological features, if it is amenable to partial nephrectomy, I would do a partial nephrectomy rather than a radical nephrectomy.
Right. So excellent. So excellent talk, Professor Hammad. And I would like to thank you personally as well as on behalf of SIUT. You have made our day, and not only our day, we are actually concluding our year of say whatever educational activity. So this is the 31st December, the evening, and may we wish you a Happy New Year 2022. And we would like to make a wish, and that wish has to be again confirmed by you and shared by you yourself, that this kind of meeting between AKU and SIUT should go along in future also, maybe once in 2 months, or whatever you suggest, the timeline.
I mean, that couldn't be anything better to wish for the sake of academics and progression of knowledge between your wonderful institution. And I have great memories of about more than 25 years back being on the floor of this place. Really save all those memories for good times. And it will be my pleasure to be part of those academic activities. And on behalf of AKU as well, we will be very, very willing to participate in any joint activity. So thank you very much. And we are open to any kind of discussion on this subject. We have benefited from the vast experience of Professor Manzoor and reconstruction, and he is always part of our curriculum. Sajid in our pediatrics. There are experts in stone disease and BPH and reconstruction and transplant. So you have masters of all those specialized areas, and we will be able to participate, to learn more from your experience as well, anytime.
Right. So we'll delve into different kind of subjects and chapters of urology in future also, not only in oncology, but also other topics. And I will share with you in future. Right. So thank you very much. And thanks once again. And this is an applause for yourself. It's for your homecoming also, because this was your birthplace.
Yes, indeed.
Many years back. And you are the one who pulled me here and left me here.
And I know you will do a much better job than me. So
Okay, thank you very much. Khuda Hafiz.
and to all of you, thank you very much. Have a nice year and Happy New Year.
Thank you.